So kicking off the second half of our session, we're really delighted to have State Senator Bo Watson here with us today. Senator Watson represents part of Hamilton County. He was elected to the state Senate in 2006 after serving one term as state representative. He's the current chairman of the Senate Finance, Ways and Means Committee. He has previously served as the Speaker pro tempore of the Tennessee Senate and the chair of the Senate Government Operations Committee. Senator Watson is a graduate of the University of Tennessee at Chattanooga and the University of Tennessee Health Science Center in Memphis. He is a licensed physical therapist and the market director for therapy services at the HCA Park Ridge Medical Center in Chattanooga. We're really happy to have you here with us today, Senator Watson, to talk about your efforts on this legislation.
Well, thank you, and thank you to the panelists. I have to say that they haven't left me a lot to talk about. They've done such a wonderful job. Your experts have done such a wonderful job, at least explaining what balance billing is. I would say that the people who have been on this call or in this conference now know more about balance billing than about 90% of the legislature and probably 99% of the public. It is a complicated issue that obviously has no simple resolution and has actually a lot of different solutions, and depending upon where you live or the state that you live in, may have a different solution. I'll just tell briefly about my experience with it and why it's an important issue to me, my legislative experience with it, that is, and why it's an important issue. And as people have already pointed out, it is rising to the top as one of the key healthcare issues that need to be addressed. As a matter of fact, the current administration has said over and over again that they would like to see the end of balance billing. But because it's complex, talking about it and doing it are two different things. I'm particularly looking forward actually to hearing from our friends in Georgia. That has been a piece of legislation that I have been looking at. To those on the call, Tennessee has 8 states on its border, which is more than any other state. There's another state that has 8. And so we watch what happens in our neighbors' states to help guide us in decisions that we make in Tennessee, whether it's health policy or it's tax policy. Because we have such a dependency upon the states that surround us as a landlocked state, it's important to know what they're doing. So I was happy to see that the friends to the south of me here in Chattanooga, where I live, made progress in balanced billing, and I hope that gives us some inclination. I have been at this now for about 6 years. For full disclosure, and I think you said so in my introduction, I work for Park Ridge Medical Center in Chattanooga, Tennessee, as a physical therapist. No clinician wants to deal with the business side of this. That's not what people got into healthcare for. No hospital wants to deal with the business side of this. They got into the business of taking care of people. And one of the things that drives clinicians most crazy is having to deal with the financial aspect of taking care of patients. They just think it should be a separate part of what they do. And so hospitals and providers really would like to see this problem go away. The legislation that I introduced, and Ms. Kumar, she referenced it. Mine was a combination of a benchmark legislation combined with the opportunity to do independent dispute resolution. Here's the challenge. There are 2 camps. You have the provider camp, which is made up by the insurance company. So if I introduce a bill that seems to, the provider camp, which is made up by hospitals, doctors, etc., clinicians. If I introduce a bill that seems to favor the provider camp, then the other camp, which is the payer camp, will introduce a piece of legislation to balance out against what might be in my legislation. And true to form, that's what I've experienced over the past 6 years. Every time I file a bill that the insurance company seems to favor, believe favors the provider, they will introduce a bill that does the opposite. The challenge of this legislation comes down to a couple of things, and this is not going to be unfamiliar to folks on this call. And that is who gets paid and how much they get paid. I mean, that ultimately is the question. The providers believe they should be paid more in many instances, and the payers believe that they should pay them less. And as you know, when people are talking about money, everybody has their own perspective of what's appropriate. What everyone does agree on, which my legislation also contained, is that patients are not responsible for any of this. This is a negotiation or a problem that should be solved between the providers and the payers. And that patients in most of these instances, beyond owing, their deductible or those kind of things that are a part of their normal insurance contract, that patients really should not have to deal with this. They're usually under the stress of a medical condition as it is already. And clinicians, hospitals, and payers all agree that we should figure out a way to eliminate the patient from the conversation. The challenge with benchmarks, both agree that benchmarks are a good idea, both the providers and the payers. The challenge that I face with benchmarks is, well, who gets to decide what the benchmark is? So the payers, the insurance companies, would prefer to use Medicare rates as the benchmark because Medicare rates are universal across the country. Everybody knows what they are. They're publicly available. There's variation in those rates depending upon what city you live in, what state you live in, and they believe that that's a fair way of setting the benchmark. Providers disagree. Providers believe that there should be an independent entity which sets what the benchmark is, again, taking into account where people live and those kind of things because of the variation that we have in healthcare costs. But they believe it should be an independent entity because Medicare or Medicaid rates are often seen as the floor for payments. So the first challenge is figuring out, if you're going to do a benchmark system, figuring out who gets to set the benchmark is. The second part is the independent dispute resolution. Insurance companies don't want to see independent dispute resolution. They don't want an arbiter to come in and make a decision for what should or should not be paid. They think there's sufficient data that provides what that number should be. On the other side, the payers believe that if they can't come to an agreement around the benchmark, then that the payers should have the providers should have the opportunity to seek resolution of payment from an independent entity that establishes what the payment should be based on the conditions in the community where that provider happens to be working. But again, everybody agrees that this is not something that the patient should deal with. The patient should be dealing with their medical condition and not with the business side of healthcare. So the bill that I introduced, of course, can't address ERISA plans. And using round numbers, in the state of Tennessee, about 60% of people are covered under ERISA plans. About 40% are covered under other types of plans. The largest other type of plan, of course, being the state health plan, as well as have TennCare and those kind of programs that would be addressed as well. So bringing these two groups together has been difficult. The strategy I attempted to use, and later in this discussion, I'll be interested to hear again from Georgia and others. I attempted to take, there's no sense reinventing the wheel. All of the insurance companies that we're dealing with in this negotiation have insurance companies in states which have gone through this process already. So when they make the claim how difficult this would be, it's just a false narrative because they've already dealt with it in other states. They should be able to work with the payers and the providers, and payers should be able to work together in this because this has been resolved in other states. I looked first at New York and what's been done in New York because New York set up an independent commission which set the benchmarks. That commission was set up for a totally separate reason, but it ended up being a good resource to set benchmarks for payment. And New York has the most experience in dispute resolution or independent dispute resolution. And after 5 or 6 years of doing it, I thought many of the challenges had been worked out. And I thought that was a good template to look at. And then we looked at the Texas model, which is a little bit newer, and combined what we thought were good things from Texas with good things from New York, added in a little bit of Florida. So we tried to perhaps create an amalgamation of a bill that addressed all the issues from many different perspectives. In the end, I have a challenging committee to work through, the Commerce and Insurance Committee in the Tennessee Senate moves very slowly around healthcare issues, has a lot of competing interests in it. And so it's a challenging committee. The bill moves a little bit easier in the House than it does in the Senate. So the political side of it is one that we're still navigating. I do believe that in this coming session, we're going to take this issue up mainly because of the pandemic or just because of momentum that we see around the country with the number of states who have now come up with resolutions to the problem. I believe we have an opportunity to make progress with this and actually pass some meaningful legislation. I hope the Lee administration will, sort of join my efforts in this and try and get something done that again, at the end of the day, saves patients from the anxiety of financial issues when they're already dealing with medical issues. And as a clinician, we do our best to avoid putting those kind of things on patients. I'll stop there because I'm really interested in what others have to say. And again, just thank you for allowing me to be a participant in the process.
Thank you so much for being here, Senator Watson. Before we move on, I just wanted to ask one clarifying question. You alluded to this in that the House has been able to actually, support legislation on this topic in the state of Tennessee before, but then the Senate has not. And last year, actually, the bill didn't get out of committee. So I was wondering if you could shed a little bit of light on why there is that disparity between the House and the Senate. I know that those were different bills. Did that contribute to the difficulty there? And what are some of the challenges that you think you'll be able to overcome in getting this out of the Senate in the coming session?
Well, the Senate, by its nature, moves a little slower anyway. Okay? The way our committees are constructed are a little bit different than the House. I would say that the Commerce and Insurance Committee in the Senate leans a little bit more towards the payer community than it does the provider community. Part of that is because, the payers will argue, and I think one of the panelists have already referenced this, that premium rates will go up. Well, I challenge that narrative and just ask, when have premium rates gone down? So if we don't do balanced billing, will they reduce the premium rates? And again, as I've alluded to, this has been done in a number of states. I can't remember the exact number, but let's just say 30 for round numbers. So 30 states have figured out how to do this, and I haven't heard this outcry from those states that that premium rates went up significantly more. I mean, when some premium rates are going up 15, 20, ask your private employers, rates are going up 15, 20, 25% anyway. Really? Do you think this is going to be that significant of an issue? But that has been a compelling argument that, we have seen in the Senate. The House has been less inclined to accept that argument. But I don't want to, those are the kinds of things that legislators have to work through. And I think having a really good discourse on this in the next legislative session and considering the environment that we're now in, I think the Senate's going to be more open to having the discussion. I will say that just for clarifying, the bill, I did not ask the Senate Commerce and Insurance Committee to vote on my bill. Good legislators know where their votes are and whether they have them or they don't. And the votes weren't there to get this bill out of committee, so I did not move the bill forward yet, like the House had done. So it's in a good spot. Many members have now gotten engaged in this discussion, much more than were 4 to 6 years ago when I first started talking about this. And interestingly, and I know I'm going on here and I apologize, but interesting, the legislation introduced it to show you how challenging this is. 2 bills that were introduced at the federal level. One was by Lamar Alexander, which one would say probably leaned toward the payer community. A second bill in the House was introduced by Representative Phil Rowe, both of the Tennessee delegation, different bills, and the Phil Rowe bill probably leaned toward the provider community. So here within Tennessee's own federal legislative delegation, we have members who introduce balanced billing legislation that has a little bit different slant on it, thus the problem at the federal and the state level.
Thank you, Senator Watson. I think that really sort of sheds some light on where we're at on this issue in Tennessee.